Now joining Kathleen on stage, please welcome our panel of experts to talk about breast cancer screening and policy. Ricki Fairley, co-founder and CEO of Touch, the Black Breast Cancer Alliance. Molly Guthrie, Vice President of Policy and Advocacy at Susan G. Komen. JoAnn Pushkin, Executive Director at DenseBreast-info Incorporated. And Dr. Christine Edmonds, Associate Professor of Radiology at the University of Pennsylvania Health System. Welcome.
Welcome, welcome, ladies. Thank you. So I want everyone to know what you guys are working on and know a little bit about you. So I was wondering if we can go down the line and have each one of you share what you consider as a major gap when it comes to breast cancer screening in the United States and how your organization is tackling it. So Ricki, would you start us off?
Of course I had to be first. Thank you. I'm so happy to be here. You know, black breast cancer is actually a different disease. We now have science that validates that a black breast cancer cell looks different from a white one. And we're tackling that from all aspects. We also know that black women under the age of 35 get breast cancer at twice the rate of white women and die at 3 times the rate. So a 40-age screening age is too late for us. So we're really trying to understand, you know, how to look at it differently. We also know that black women have about 8% have health insurance, but 45% are underinsured. So when it comes to that diagnostic screening after a not so great mammogram, it's $2,000 to get an MRI, and I walk away from that. We're also getting screened later, and I think that the Congresswoman talked about her experience about waiting 3 months to get a mammogram. That's very, very typical, especially if you're under 40. It's really hard for them to get a mammogram, so we're really trying to talk about what's different. We also know we had talked about stigma about breast cancer. The Ad Council did a study a few years ago, and we found that 92% of black women are aware of breast cancer. Everybody knows about it. 25% of black women actually talk about it with their friends and family, but only 17% act on the risk.
Wow.
So those numbers are pretty devastating if you think about people just aren't talking about it, aren't aware of it. And a lot of it's just lack of understanding and lack of knowledge about how important it is to check your breast and get screened.
So what is your group doing specifically?
We are doing,
on those
we
issues?
actually have an outreach to young women. So we have a web series that we do every month called Pink Table Talk, and we talk to women who are healthy about breast health. We talk about helping them understand their risks, understanding her story, talking to their families about their health history, and also making breast health an act of self-care. And we educate about the importance of breast health. We have an HBCU internship program. So we hire about 10 or 15 interns every semester from HBCUs. We pay them to do our TikTok. God forbid, I don't know what's on the TikTok. I'm not too old for TikTok, but we engage them to talk about breast health with their peers and with their families. So it's really important to hit them at a young age to understand what they're up against, what their risks are, and that breast health should be an act of self-care.
Very smart. Yeah, especially addressing young women, because that's the group where we're seeing the rate of breast cancer go up the most quickly.
We also have a nurse navigation program where we have 24/7 navigators. Our navigators are all black women. They're all breast cancer survivors, so they can talk the talk because they've walked the walk. So we have them counsel families, counsel patients, counsel people, and we really try to engage them, hopefully before the patients need them.
Molly, you're with Susan G. Komen. I mean, I know you're doing so much, but what is the gap you're trying to fill when it comes to screening?
So at Susan G. Komen, more broadly, you know, one thing that makes us unique is that we really go after these issues with a 360-degree approach. So I wear the policy and advocacy hat, and so we, you know, obviously focus on legislative and regulatory change, but more broadly, we know it's important to invest in research, and so, you know, we invest in research at Susan G. Komen. We also, similar to Ricki, provide immediate care and assistance to patients going through this experience, whether that be someone calling our helpline to just figure out what to do, or maybe they need financial assistance to be able to cover the cost of their screening. And then again, all of that is really underpinned by education and our policy work. In the policy space, we have an ever-growing portfolio of issues that we're having to address, unfortunately, that our community is facing. But looking specifically at screening, really the whole reason we're here today, right? We know that all people should have access and equitable access to affordable and high quality screening, healthcare more broadly for sure, but specifically on screening. So in addition to the ABCD Act, we also spend a lot of time advocating for the National Breast and Cervical Cancer Early Detection Program, which is a fantastic program housed out of the CDC that's been in existence for 30 plus years now. And to Ricki's point, we know that already there was a large uninsured population, underinsured population, and unfortunately that population is likely to expand and grow. And so this program provides, from the beginning all the way to, screening, diagnostics, biopsies. If you're diagnosed, then you can be navigated into treatment. And so working really across the spectrum, regardless of your insurance type or if you're uninsured, to really get us to a place where there is equity and that people can get the screening they need, when they need it, where they need it, and not have to face administrative and financial barriers to that.
Now, JoAnn, I know your focus is dense breasts.
That's it.
So what are you doing?
So 40% of women have dense breasts. For those women, they are at increased risk of developing breast cancer and of having that cancer missed on a mammogram. In women with the densest breasts, a mammogram will miss about 40% of cancers present. That's almost a coin toss. They're also at an elevated risk of developing breast cancer. So I and fellow advocates fought for density-informed laws state by state, and finally in September of 2024, it became an FDA requirement that all women after their mammogram be informed whether their breasts are dense or not dense. So armed with that information, that certainly helps the screening experience for a woman because now she knows she has dense breasts. We would like everyone to ask them the question, is my mammogram enough? Because that's the question that should follow. And if the answer is, oh, dear, you need more screening, that screening should be covered. Because for women with dense breasts, if 40% of cancers at least are missed, that's incomplete screening. Mammograms are not as effective for all women. So for women with dense breasts, it's a compromise tool. And to complete that screening cycle, they need more screening, and they should be able to afford it. And so we're supporting the ABCD Act and the Find It Early Act. Now that it's federal requirement that women be told they have dense breasts, what the complement to that now, of course, is insurance that they get the screening they are now told they probably need.
So Christine, you are the doctor on the panel. So tell us about what you are tackling in this area.
Sure. So I am faculty breast radiologist, and I'm thinking, hearing everyone else mentioning what they're talking to, I don't even know where to begin. There are so many different aspects that we are working on, but I'm going to highlight, for the sake of brevity, two key ones. One, time to diagnosis. That is key. As we heard from our Congress members and people on this panel already, it makes a huge difference. So whether we are decreasing time to diagnosis and subsequently time to treatment by getting women in through screening or diagnostic imaging, i.e. they feel a lump, they have a symptom like that, then they need subsequent imaging, then they need a biopsy. So as you can imagine, time accumulates at each of those steps. We have good data that with those increases, what we might think is a relatively small increase in time. So up to 60 days to start your treatment, if that's frequently surgery up front. That's not very long. So if from presentation to surgery, you go beyond 60 days, not very long, when you take into account all the other things that have to happen, the biopsy, extra appointments, et cetera, you're already having increased mortality when you hit that 60-day mark. Beyond that, additional 30-day intervals, same thing. So time is of the essence, both for screening and diagnostic. So we're focusing on that. Within that, as you can imagine, we have tremendous disparities. My colleague here mentioned some of them. We have racial, ethnic, socioeconomic disparities. We have to work to address those. Second key area, we need better biomarkers to figure out who needs what screening and when.
Can you explain to our audience
Absolutely.
what a biomarker is?
Yep, so it's sort of a big collective term. It is some sort of marker of biology. And it can be a blood marker. Some of you have probably heard about blood tests that are looking for things like protein or DNA, things that can show if you have cancer now, but can also show if you might get cancer or at heightened risk of cancer in the future. As a radiologist, I'm also interested in imaging biomarkers. Density is the example that most of us are familiar with. So not only does having increased density elevate your risk of developing breast cancer, it of course makes the mammogram less sensitive, which JoAnn just mentioned to us. So imaging biomarkers, density, and ones that go beyond, things that look at enhancement of the fibroglandular tissue in the breast. So looking at the biomarkers so that we can figure out who needs regular screening, who needs supplemental or high-risk screening, i.e. things like MRI. Not just who needs it, but when do they need it, right? All of these resources are limited, cost, access, etc. So not only are you at risk, but when are you at high risk in your life? Is it this 5 years, or is it 20 years down the road? So that we can better deliver the care to the people who need it, while making the care more equitable, right? Some of the biomarkers, for example, density that we use right now, aren't particularly equitable. That biomarker is more helpful in white women, for example, than it is in black women. So putting that all together, we are doing research at my own institution to develop those biomarkers, test them, and simultaneously to make the care that we do have, screening, diagnostic care, et cetera, more accessible to our communities, targeting specific communities in and around Philadelphia that are underserved currently, our Black communities, our Latina, Hispanic communities, through specific pilot interventions with the ultimate goal of getting the time to diagnosis down.
I have to follow up on that. So why is breast density not a good biomarker for women of color?
That's a great question. And I wouldn't say it's not good. We certainly don't want to ignore it. It's not as good for white women. Part of that...
For black women?
Excuse me, for black women, thank you. Part of the reason that it is not as good for predicting risk in black women is that it is at least tied to BMI and body size. So when we talk about breast density, the way that we currently evaluate it as the radiologist is usually just a quick Gestalt qualitative assessment. And it's a ratio of the fibroglandular tissue. That's actually the breast tissue, the cells where the cancer develops and then spreads. It's a ratio of that tissue, the fibroglandular tissue, to the fatty tissue. And so when we use a ratio like that, you can imagine if body habitus is larger, the body overall has more fat, then that proportion of dense tissue is going to look qualitatively lower compared to the fatty tissue in the breast. And so unfortunately, if we use those qualitative assessments, black women are less likely to be candidates for supplemental screening if we rely on those qualitative density assessments. So unfortunately, we've already heard black women get breast cancer at younger ages, present at at higher stages, and have 40% higher mortality. So the very population that you might think, wow, they're going to need some extra screening here, are unfortunately a little bit less eligible if we're using simply that density biomarker.
Well, Ricki, I'd like to go to you. I'm sure you have a lot to chime in on with that, because as you touched on earlier, I mean, breast cancer for black women, it's almost a different disease.
It is.
Right?
It is.
And share your experience, if you would, because we do have 2 breast cancer survivors on the panel, you and JoAnn.
Black women are 3 times more likely to get triple-negative breast cancer.
That's what you had.
Which is what I had, which is the most aggressive breast cancer. It's the only breast cancer that does not have a drug to prevent recurrence. And it recurs very readily. Mine came back after a year. So I was diagnosed with stage 3A. And actually, I think the number is black women are 3 times more likely to get stage 3 or 4 breast cancer, which is what I got.
I have to ask you, why is there no drug to prevent recurrence for this?
We don't have one yet. So you may have heard of taking tamoxifen for 5 or 10 years or whatever. We don't have a drug. It's the only breast cancer that doesn't have it. And it's the breast cancer that doesn't have the other biomarkers that most breast cancers have. I was diagnosed at stage 3A. I had a double mastectomy. Yes, these are fake boobs. I did standard of care chemo. I did 6 rounds of radiation, 6 weeks of radiation.
And what year was this?
This was in 2011.
2011.
So we really had nothing for triple negative back then. Now we have 2 targeted medications. But I was told I had no evidence of disease. After 8 months of treatment, come back in a couple months for a scan. I came back exactly a year to the day of my first diagnosis, almost. And I had 5 spots on my chest wall. My doctor said, okay, we have nothing for you. You need to get your affairs in order. You probably have 2 years to live. I said, I can't really die right now. I have
no time for this.
I have a daughter at Dartmouth. I have to pay tuition. I got to get my kid through school. She was a sophomore. So I had to figure out what to do. And I went and advocated for myself. I went to Dr. Google. I did all the things. I found a doctor who put me on a clinical trial for another drug where they were testing for triple negative at the time. I did a lot more chemo, and I didn't die. And a month ago, I celebrated 14 years.
Woo. All right.
So this is my God job. This is my God job. I know God left me here to do this work and talk to Black women. But we also know that Black women are 58% more likely to get de novo breast cancer, meaning it's metastatic from the get-go. And we don't really know why. I mean, our breast cancer is different. We now know the cells look different. So we have a lot to do to understand, how to help Black women, and they really need screening earlier, and we really need diagnostic screening earlier and more readily. So we have to work on that.
Well, and one thing I would add, just adding to these 2 points, is specifically looking at the ABCD Act. We refer back to NCCN guidelines, and so those guidelines.
NCCN, explain to the audience who might not know.
They are a guideline issuing body that follows the science, the research, the data, and so they stratify out by risk. So density is part of it, but there's also genetic mutations and family history and other components, and so it expands the eligibility, right? It's not limited to say that you have to be 40 or older, or it's only for follow-up, especially for that supplemental imaging. And so that's what we've found through the many years of our work at the state level, to find to be the most expansive for being reflective of what we know about risk, to ensure that people are getting the imaging when they need it, but also the type of imaging and the frequency that they require. We are still losing far too many women and men to this disease, but we know so much more about it now that we can, get people, if we can create equity and access, we can get people the right screening, the right diagnostics to get them to an earlier diagnosis for a lot of the population.
But that guideline is still for age 40. And that's too old for Black women. We're getting it younger. Black women under 30 have a 50% higher mortality rate of breast cancer than white women. And so we have to change how we think about screening, and not only the diagnostic screening, but the age is so important. And that's a whole nother act that we're trying to.
And that's going to have to come from the FDA, right?
Yeah.
For it to be covered.
But just to clarify, the NCCN guidelines aren't limited to only 40.
That's true. And
there's a whole other governing body that
it does that.
We won't open that can of worms.
I know. No, but what we encourage is for Black women, and what doctors recommend is for them to get a risk assessment at age 25. Wow. And a risk assessment.
Is that covered by insurance?
It's usually, it depends. It depends on your insurance. I mean, and most of the time you can go to your gynecologist and get a risk assessment, and they'll refer you to a breast surgeon or something. But it requires insurance. It requires, and probably good insurance to be able to do that. But we know our disease is different because there's a study done by Emory, Lauren McCullough. She's an epidemiologist at Emory, and she did a study a few years ago, and she found that Black women who have equivalent insurance to white women still have a 60% higher mortality rate of breast cancer than white women. Black women who live in a high socioeconomic neighborhood still have a 126% higher mortality rate than the white women in the same neighborhood. So that's why we know the science is different for us, and we need to consider all those things.
Yeah, sounds like we need a lot more research into that. It's so fascinating to me to see women who are survivors like you, like JoAnn, who you are driving so much action in this area. And JoAnn, I wanted to talk to you. You helped push the FDA to finally put out these requirements that, radiologists say, inform women, you have dense breasts, and this is how dense, and this is what that means. How did it feel to have accomplished something like that? And what are some remaining misconceptions and misunderstandings about breast density that you're working on today to change?
I think when we got word that the FDA agreed that, yes, we're going to come out with the guidelines, and they came out with them, I remember getting the news, and I just kind of sat down heavily in my chair and thought, excuse me, Jesus Christ, I'm glad it's over. I just thought this was this just took so long to get this done, and there were so many women in so many states fighting, frankly, while they were dying, to be sure getting chemo, getting an infusion and typing on their other hand to lobby their state legislators for women to be told this information. Why should we have fought so hard to be told this information? Why was that a secret? Why wasn't I told I had dense breasts? Why, when I was finally diagnosed, I was going for mammograms, doing everything right, healthy girl, ate right, and one day I feel a lump, but it had only been 8 weeks since my normal mammogram, and I really wasn't worried, but they tell you call your doctor. Of course I did. And I went right in, and he palpated the lump also, sent me on for a diagnostic mammogram and an ultrasound. And I go for the mammogram, and the day the lump is so big, I can feel it. I've got no better background. I can feel the lump. It doesn't show up on the mammogram. And the aide comes back in the room and says, the mammogram is clear. And I was in a large facility with multiple waiting rooms. And I said to the girl, oh, honey, I think you came back into the wrong room. I'm the lady with the lump so big I can feel it. And she says to me, oh, honey, you've got dense breasts. We're never going to find that. And I remember sitting back, and my thought then involved the F word.
Wow.
And then, right. And so, but then I go for the ultrasound, and there it is, clear as a bell. And so, of course, my question is, but so now why wasn't I getting that ultrasound every year? And when I check my medical records, and by the way, by size and stage, the cancer was estimated to have been growing 3 to 5 years in my breast, undetected, every single one of them by mammography. And every one of those 3 to 5 years, I get a letter after my mammogram telling me my mammogram is normal. Women with dense breasts are not aware that getting a letter that says your mammogram is normal is not a reliable indication that cancer isn't present. Right. So when I get the reports then, I was so curious about this dense breast. What is this term that this person is using? I mean, every single one of those years, the report that was sent from my breast imager to my referring doctor mentioned my extremely dense breasts. So my doctor knew I had dense breasts. My radiologist knew I had dense breasts. Who didn't know? Me, the patient.
Let's talk again about some misunderstandings or, like, for instance, women who have dense breasts, they change over time. Like, so when you hit menopause, then you might not have dense breasts. I mean, just help us with misconceptions.
The younger you are, the more likely it is that your breasts will be dense because it is a function of hormones somewhat. And generally, they get less dense as you get older. My mother is 88 years old with dense breasts. Wow. So it's not that it's a guarantee that it will decrease.
Interesting.
I believe the number is 60% of black women have dense breasts. So for us, we have dense breasts plus all the other stuff that's going on. So, and we don't even know. We're the ones who aren't getting mammograms, are just really at risk.
Christine, I wanted to talk with you a little bit about MRIs, because I understand that you have studied the optimization of breast MRI screening and diagnosis. So what have you found, and how can MRIs be used in the future to detect more disease?
Sure. So MRI, for those less familiar with it, that's magnetic resonance imaging. And when we are talking about it for breast cancer, we're talking about with contrast enhancement. So a type of dye that is injected through the vein before the MRI. One nice thing about MRI is there's no radiation. So while most medical imaging or a lot of medical imaging has radiation, we do need to keep in mind it's very, very low dose, generally quite safe. MRI has none, so that's nice. MRI is highly accurate for diagnosing breast cancer. In particular, it has very, very high sensitivity, which means that if there is breast cancer in the breast, even if it's small or early stage, such as ductal carcinoma in situ, that's when the cancer cells are still in the duct, or a very small tumor, i.e. when we want to diagnose it before it has spread to the lymph nodes or beyond, MRI has a high sensitivity for that. Now, we all know no tests are perfect, right? So what are the downsides of MRI? I've just told you it finds cancers really well. Well, it's expensive. It's very expensive. Currently, there are many issues with insurance coverage of MRI. So even if your insurance company says they cover MRI, there is frequently cost sharing, meaning a high out-of-pocket cost for the patient. And that can be the case for screening. So what I mean by screening is somebody who has no signs or symptoms of breast cancer. So why would they be getting an MRI? Well, currently, that would be because they are at higher risk than the average person. So generally, higher than 20% lifetime risk. Lots of ways to calculate that, lots of online mathematical models to calculate that. Those patients should be getting screened with breast MRI every year. Probably at least a subset of patients who have dense breasts should also be getting screened with breast MRI because, as we've already heard, mammogram is not perfect in anyone, but it is more limited in patients with dense breasts.
So how much better is an MRI than a sonogram, which often women with dense
that's
breasts are
such a good
sent to
question.
get? Because I have dense breasts, and they
Yep.
would tell me, oh, now
Yep.
you need to go get a sonogram.
Yep. So MRI, unfortunately, because it is more expensive and a bit less accessible than ultrasound, is more accurate than ultrasound. Also, part of the problem with ultrasound, so when we think about screening mammography should diagnose, on average, about 5 cancers per 1,000 screened. If we do supplemental ultrasound screening, so an ultrasound of the entirety of both breasts,
After the mammogram.
correct, that's going to pick up a couple, 2 to 3 extra cancers. You think about that, that's pretty good. But there are some heavy costs to that, which is why it falls a bit lower on the list as far as what's recommended for supplemental screening by some groups, NCCN, as we've already heard about, ACR, American College of Radiology, and the Society of Breast Imaging. What are those costs? Well, it finds a whole lot of things that we cannot tell if they are cancers, resulting in a lot of follow-up and unnecessary biopsies, so what we call false positives. So that's the challenge with ultrasound. So no test is perfect. MRI also, of course, has false positives. It's expensive. So those are the 2 main strategies that we use, at least for supplemental screening. So I'm talking about women with dense breasts who need something extra. If you're at high risk, and that's because of genetics or family history, strong family history in particular, there really isn't a question. MRI is what you want for your high-risk screening, not ultrasound. So that's fairly clear.
But no cancer should fall through the gap.
Right.
It's not acceptable.
Well, for Black women in particular, when we talk about the screening gaps, what are you seeing, and how do we close those gaps? Are they greater than ever for women of color?
Well, I think it's just knowledge and understanding what cancer, what your family risks are, what your family history is, and access to care. Access to screening. Can you afford it?
I mean, are doctors less likely to recommend that MRI, that ultrasound?
Yes, they are.
So you have to advocate.
You have to fight for yourself. You have to advocate for it. My daughter, she's 39. When she was 39, so I don't have any genetic mutations, but I have a family history. My mom had breast cancer, and my mom's aunt had breast cancer. She died at age 42. And so my daughter, at 39, she had 3 babies. She nursed her baby. She's okay. I'm done with my breasts. And so she wanted to get a mastectomy. So we had to go through all the screening to make that happen. And we had to pull a lot of strings and talk to a lot of people and do a lot of begging to even get her a mammogram at age 38.
What did they find?
So they found nothing on the mammogram. Then she had a sonogram. They found a suspicion on the sonogram. Then she had an MRI, and they found a suspicion. By that time, she had already scheduled her mastectomy, and so she was able to get it. Probably had she not done that, she would have gotten a biopsy. So we don't think she had cancer. It was probably a low likelihood, but she did have an 81% risk of getting breast cancer. So she had a prophylactic mastectomy at age 39.
That's a huge decision.
But I think she was educated enough because of the work that we do to be able to do that and make that choice for herself. And everybody should have an opportunity to make a choice if they have a family history, if they have the BRCA gene or genetic mutation, to do that. And it shouldn't be a financial issue.
Molly, speaking of financial issues, that's what the ABCD Act is all
Yes.
about, removing that so that women can get these additional screenings. And I know Susan G. Komen, in addition to working on the national level for the ABCD Act, you've taken the fight to the states.
Yes.
Talk to us about that and how successful you've been there.
Yes. Before I do that, I know in the first conversation, the infamous M word came up of mandate. So I do want to provide just a little bit of clarity there, because the vast majority of insurers already cover the screening, right? They are following NCCN guidelines as far as coverage. The issue, to your point, is that financial component. And so while it's covered, it comes at significant cost to the patient. And so we frame it as a really cost adjustment issue rather than a new mandate for coverage.
Thank you for clarifying.
Which I share, because I think that's part of the reason that we've been so successful at the state level. So As we heard, things tend to move slowly here in Washington, D.C. And so when we started hearing from our community, goodness, probably a decade ago now, about confusion post-ACA, right? There was all this promotion that screening is covered, no one's going to ever have to pay out of pocket, you can get an earlier diagnosis. People were confused why they then were still being told, well, you have to pay $50, a couple $100, $1,000 out of pocket to get this imaging that you need. And so, come to find out, that was that division between regular screening or supplemental screening and diagnostic imaging. So we dipped our toe in the policy solutions at the state level first to see what would work, what sort of resistance we would come up against. And so did that for a couple of years before first introducing the ABCD Act back in 2019, I believe. So we started in 2017, 2018. Well, there's still a few states pending this year, so we might see that number go up. But as of today, there are 30 states that we believe provide the coverage at no cost and for the number of screenings that might be required. So really comprehensive coverage in 30 states across the country. And those are big states, small states, red states, blue states, rural, urban, really the whole continuum. We're seeing this real momentum at the state level, which is huge, right? To date,
Huge. That's huge.
we've removed that financial barrier for 130 million women and men across the country, which is massive, but there's still a huge gap that exists, which is why we need this federal law to have consistent coverage for everyone, no cost coverage for everyone across the country.
I'm curious what they found in those states, because I know the concern is it would raise costs. So that women would, for some reason, suddenly rush out to get ultrasounds and MRIs because it's like a
what
massage
we all want,
or something.
Right? More testing is what everyone
Right,
wants.
it's so much fun.
Right.
The data has come back in pretty much all of those states that have done cost analyses that the cost is minimal. The cost to the insurer is minimal, and the increase to premiums for individuals is nominal. And again, I think that goes to what we heard earlier and what we all know. If you catch cancer earlier, it's not only better outcomes for the individual, but it's less expensive for that person, and it's less expensive for the healthcare system overall. So the cost fear hasn't materialized, and interestingly, when we first started these efforts, and JoAnn and I have been working in many of those states together, but when we started those efforts, I would say the insurance companies came out in full force, everything against getting these bills passed. And I think the data has shown that perhaps there's not as much fear as there should have been. And so there's still some opposition, but it's not at the level that we have seen historically, most recently.
Because it's saving lives through early diagnosis and therefore saving money to the healthcare system at large and to the insurance companies, one would assume.
Absolutely.
Right.
Yes.
JoAnn, you mentioned earlier in your first comments, you support not only the ABCD Act, but the Find It Early Act. And I don't think we all in the room know what the difference is between the two. Could you explain that? And would the passage of either one be equally helpful?
So they're both federal bills to expand and reduce the out-of-pocket costs associated with screening and diagnostic imaging, both based on NCC and guidelines. The Find It Early Act covers federal plans like Medicare, VHA, and TRICARE. So it would include, in addition to the private plans, some of the federal plans.
Okay, so the ABCD Act does not cover those.
Yeah, so the ABCD Act was introduced first. Again, it was introduced in 2019. And when we talked to committees of jurisdiction, there was more willingness to move forward a bill that was focused on this private insurance component. We absolutely agree that it needs to be addressed across the landscape. But again, things move slowly in DC, and larger scope bills can be more difficult to move. And so when Find It Early was introduced a couple years ago, we still felt it was important to reintroduce and continuing to push ABCD, because if we can get a bite of the apple for private insurance, and it will make it easier to get coverage in Medicare and through TRICARE and other federal regulated insurance. But we worked with Deloro's office on the language is purposely very similar because we felt it really important. Again, the issue remains that we need access to supplemental and diagnostic without the cost. So they are very, very similar in text.
And can I just say this, no matter what passes and no matter how hard we work, none of these efforts is going to stop these women from getting breast cancer.
Right.
And so the question is, when are we going to find that breast cancer? Are we going to find it when maybe she has a lumpectomy and she goes back to work the next day? Or when now we're talking about a life-threatening illness and her kids losing their mom and a family losing a family member? When are we going to find it? And so that's the question. And so early stage cancer is easier to treat and saves these families and keeps them intact. And that's the whole purpose. I mean, screening is either important or it's not. And the reason we screen is to find it early.
And it's really unfortunate that we even have to talk about this. I mean, it's crazy. I forgot to mention something that we also do is that, it's really important to be in the community, and that's what Komen does, and that's what we do every day. And we do about 100 events across the country, and at about 30 of the events that we can afford, we do screening at our events. And we screen young women. We particularly screen young women who are under 40 because they can't get a mammogram. And so we have a lot of different things that we use to do that. But for example, we went to Martha's Vineyard last year, kind of where all the bougie black people go in August. It's like a thing. The black women know what I'm talking about. And we scanned, we did DEXA scanning on 55 women. We found 3 cancers in 3 days. This year we did it again. We scanned 158 women and we found no cancer, thank you God. But I think we were in the community and actually 40 of the women that came back from year to year to get scanned because it was easy for them to do. They're on vacation, but we try to bring it to the community so they don't have to do it themselves. But I think it's really important just to talk about it and be where people are and meet them where they are to understand the importance of this.
Christine, I was wondering if you could look down the road, really to the future for us regarding imaging, and are there any innovations that hold really great promise, say over the next 5 to 10 years, to improve early detection, to reduce false positives?
Yep, there sure are. As I mentioned previously, one of the key issues is figuring out who needs something extra, be it ultrasound or MRI, and when do they need it. So there are some really promising research studies coming down the pike. Most of us in the room by now are familiar with AI, artificial intelligence. Within that subset, that large umbrella, we have machine learning, and then under that, we have deep learning. And we won't go into the weeds on that today, but basically using these neural networks, these very advanced computer algorithms, to either take a single imaging feature. For example, there are these amazing studies showing that using a single mammogram, we can predict with better accuracy than, say, all of the online math models that we have right now, not only who is at elevated risk of breast cancer, but when, narrowing it from a lifetime risk to a 5-year period. So that's huge.
And that's using AI?
That's right. That's using AI, just with a mammogram image. Not only that, it is more racially, ethically equitable than the models that we have online now that have always underperformed in certain populations, including Black women, Latino women, partly because they were not developed and tested in those populations. So not only are these better tools, they're equitable tools, there are some also really interesting studies that if we combine that with a few very interesting but easy to get facts, where you live, what neighborhood you are from, right? Your neighborhood deprivation index, your family history, et cetera. Information that should be pretty easily accessible. Combine that with an image, these models are amazing. So obviously that's not in clinical use right now, but it could be in the near future. The studies are amazing.
I would say, though, that I get calls every week about, so my doctor said if I pay an extra $40, I can get the AI mammogram. Should I do that?
I'm getting one in like 2 weeks.
Yeah.
What's the deal? Is that,
and I said, well,
I said yes.
And so, no, you should. I said, if you can afford it, yes, do it. But still, I don't think we have data to validate that we have enough Black women in that research to make a statement about it. So I say do it because we need your data.
Yes. And I will add those tools, CAD, for example, that helps radiologists see calcifications, et cetera, sometimes get lumped in with those AI mammograms.
Right.
And that is not the same thing as what will hopefully be
Right.
coming down the pike and is not yet available now. In the shorter term, we have contrast-enhanced mammo, which is similar to MRI in that you get intravenous contrast and then you get a mammogram.
So who would need that? Who is that good
Great
for?
question.
Women with dense breasts?
Yes. So the data is lagging a bit behind. It's a newer technology than MRI. It is not quite as good as MRI, early data shows, but it's pretty good. And already it's in use for diagnostic imaging. For example, in women who have dense breasts, you get recalled, there's something vague there, you want contrast. And or women who can't get MRI for various reasons. Screening studies are pending. There's lots of data coming, but it has a lot of promise. It is a shorter study, a less expensive study, fairly tolerable to most patients. So that is also another very promising avenue. It has the benefit of not just relying on anatomy, right? So when we do mammogram or ultrasound, we are simply looking at anatomy, just looking at tissue, shapes, things like that. Both MRI and contrast-enhanced mammogram are looking at enhancement, so blood flow. Tumors have increased blood flow. So basically, for lack of a simpler explanation, they light up on an MRI or a contrast-enhanced mammogram and potentially improve the accuracy. So that is hopefully in the near future.
And it sounds, I would assume quickly, the contrast-enhanced mammogram is less expensive than an MRI.
That's correct, yeah.
I would also add contrast-enhanced mammography is really important, especially when you're looking at rural communities that don't have access to this other imaging, an MRI machine. And so we have disparities across the board in breast cancer, but another significant one is individuals in rural populations. And so CEM, contrast-enhanced mammography, is really important for that.
Yeah.
And again, included within guidelines for those purposes, so covered by both the ABCD Act and Find It Early.
80% of patients are going to community hospitals. So they're not going to Georgetown and MD Anderson. They're going to in their community where they're probably not having access to this kind of technology.
As we wrap, I'd like us to look kind of a little bit, as Christine just did there, look down the road into the future. Is there something on the horizon in breast cancer, detection, treatment, whatever, that you're excited about? Something you want to put on our radar?
For me, it's clinical trials, because we don't have enough Black women in research across the board, whether it's for diagnosis, treatment, whatever. So any clinical trial is important. We actually launched a clinical trial education campaign a few years ago, 4 years ago, called When We Trial. If you go to whenwetrial.org, and we have a portal where we recruit women to trials, all kinds of trials for breast cancer. Yesterday, we actually hit 30,234 Black women have hit our portal. So that was a pretty big accomplishment for us. But we still have more work to do. And I think that we just need more data about Black breast cancer across the board, whether it's for screening, for treatments, for anything. And so we
And do you have scientists lining up to do research with that data?
Yes, we do.
When you get it?
We do. We're part of a Cancer Grand Challenge right now with a researcher at Morehouse School of Medicine, Melissa Davis. So we are studying the disparities between Black and white cancers across the globe. It's a global study. We're in the U.S., the UK, Canada, Nigeria, Ghana, Nigeria, South Africa, Ethiopia, Kenya, and Zambia. And we're trying to understand why our cancers are different. But there's not enough research like that, and we need more. So I would say just science is really important.
Molly?
So I would echo that, but to layer on, we also know our scientific advisory board has advised us many years ago that when you look at breast cancer mortality, we can reduce the number of breast cancer deaths by 1/3 by just getting people access to the care we have in existence today. And so with my policy hat on, right, that's what I'm most excited about, is to be able to get these policy changes done so that all people can access the care they need when and where they need it without financial strain, without the administrative strain that we heard earlier, having to go get a script, or, having to have prior authorization and all these other barriers that patients face. So really looking to policymakers, whether that be at the state or federal levels or within the regulatory space, to work together with us to ensure that all people have access to what we already have today, right? It's crazy that we have it available, and we could save a third of the 43,000 people that are dying just by getting them connected to the existing treatments and screening and care that we have available now.
JoAnn?
I think all of that, yes.
And
But I think that what we need to, there needs to be some sort of more standardized approach to getting women involved in the screening program. All women at 25 should have a conversation with their health care provider about their personal history, and even a benign biopsy matters and increases your risk. Family history, her breast density, to know who should be in that high-risk channel and who should be discussing supplemental screening and what that should be. So that involves an educated patient. It involves her referring provider who understands how to assess risk, how to identify the high-risk patient, what to explain to them and what they should do. And once we get her in that office and she agrees and the doctor agrees that she should have something else, then the insurance should be there to cover that without costing her $1,800 a year for an MRI. And we hear from women every day that write into the website, I was sent on for the MRI, it was $1,800, they tell me I need it every year, I'm a single mom, I can't do that every year. And so what could be crueler than telling someone you're at elevated risk and need this screening and, well, now good luck, you know.
It's horrible.
Happens every day.
Right. And Christine?
Again, I'm struggling to pick just one that I'm excited about, but I think locally, what do I mean in my institution and my city and surrounding areas, I'm excited about some really promising strategies that we have rolled out and will continue to study and expand on to deliver the care. It's simple, to deliver the screening efficiently and get them to diagnostic and biopsy quickly, and subsequent treatment, of course. That's the end goal. Strategies like mobile mammography, specifically bringing the care to the patient, screening in their neighborhood, and hopefully eventually diagnostic too. Hospital level care, things like bundled or conditional order sets, where our providers can enter a single order that can allow the patient to go straight through in a single day, screening or at least diagnostic, straight to biopsy, and then connected to our cancer center. So those kinds of local interventions are really exciting. More broadly, I am really excited about the research. I feel like it is at our fingertips to be able to have strategies to better identify who needs screening, what they need, and when they need it. And equitable strategies, because we have made the mistakes in the past where we have done research on a very undiverse population, and we can make sure at this point that we do not repeat those mistakes. So I'm really excited about that as well.
Wow, what an amazing discussion. Ricki, Molly, JoAnn, Christine, thank you. Thank you so much. Thank you, all of us here in the room, for joining us, those who are watching live. And a big thank you to our sponsor, the Alliance for Breast Cancer Policy, again, for bringing us all together. And if anyone missed a portion of this, someone who is watching or you want a friend to watch, the full event video is going to be available on thehill.com. So thank you. Have a great day. If you're a woman of eligibility age, go get your screening. And if you're not, tell the women in your life who are to do it. Please help save their lives.
Thank you.
Thank you.
Thank you, Kathleen. Thank you.
Thank you.